The PROCLAIM Registry was really designed to collect information on patients being treated with interleukin-2. The registry started with a retrospective collection cohort and then expanded into prospectively collecting data on patients. This is particularly important because we now have a chance to really understand what might be related with good outcomes in patients getting interleukin-2, and in the modern era of oncology, really understanding how IL-2 will fit into the general landscape of cancer care given the development of other forms of therapy. It's been particularly important. I think the key findings of the IL-2 the PROCLAIM registry to date have been that the response rates that were initially reported a decade ago are still intact. We still have about a 17% objective response rate in patients, and perhaps the more important thing is that it appears that IL-2 is much safer to give. So in a very large cohort of patients, we are seeing really manageable toxicities. We're not seeing mortality that was initially reported when IL-2 first came on the scene back in the mid to late 1980s. I think in terms of thinking about when to give IL-2, it's getting to be a little bit more complicated as more drugs and other immunotherapy agents come on scene. I think IL-2 is still a very good drug. I think particularly in patients with advanced melanoma and in renal cell carcinoma, IL-2 has a role to play. I think we need to learn a lot more about the impact of sequencing on the other therapies. So there's a little bit of data that actually emerged out of the PROCLAIM registry to suggest that responses to PD-1 inhibitors was actually maybe a bit higher than with monotherapy PD-1 when patients had previous exposure to interleukin-2. Whether or not that's true will really require clinical trials to be done. But I think this is the power of the registry, is that it's given us some very important hypotheses to now go and test in the clinic. Obviously, a big advance in the field would be if we had a biomarker that could predict who will respond to IL-2 and who will not. We do have some clues, and in work that was actually done in my lab, we did identify that the pre-treatment levels of serum VEGF and fibronectin were highly correlated with response to IL-2 therapy. The SELECT trial was a study that was done to prospectively validate these as markers, as well as to look at other markers, including genome-wide panels and presence of T cells and other things that have been suggested to correlate with immune responses. That study is completed and is in analysis now, and so we're anxiously awaiting the data. If the study is positive, it might actually give us some clues as to how to better select patients with a higher likelihood of responding, and obviously then avoid treatment in patients who may not respond and would be better served with other therapy.